being able to go to the patient in some of these remote areas. I think it's all good. Okay. And conclusion, we know that climate change is going to create a lot of problems. To convince the group here. I just got a note from somebody in San Francisco who said, make sure you're talking to the people who believe climate change is real. University of California, San Francisco. They're doing some orphan drugs. So regulatory agencies are eager to facilitate development, and it's important that developers of products engage the agencies early in development. It's so important because they have rules, and their rules do no harm. So and I think we work together with groups like this that have the passion, regulatory agencies, a group like ours, and clinicians all over the world who care. I think we can make this one part of solving the problem of climate change. It's a global problem, but I think we can do it. Thank you.
So, thank you, Jules. I want to conclude the portion here. I hope you all recognize that this is a huge endeavor to not only figure out what diseases will be affected by climate change, but all the years it takes to come up with a therapy. Well, the last person I want to talk to is Larry Katz. Larry is a senior vice president at USI. USI is an enormous $1 billion plus organization. And what's interesting to me is you can do all this work, and the question is, are the insurance groups actually going to pay for it? So that's an issue that really needs to be discussed to finally get at the end. So I asked Larry, we've known for a bit, to come and talk a little bit about, from their perspective, from the insurance company, how do you find these diseases? And you have about 10,000 clients. How many clients does USI have? 100,000, something like that. The amount of data that this group collects. The question is, how do you even see that it's there? And then how do you collect it? And then how do you pay for it? And Larry's going to talk a little bit about some of that. And we'll take about maybe 5 or 10 minutes, and then we'll open up for questions. Thanks, Larry.
That's an awful lot of pressure, right?
Yeah, that's it.
How am I going to pay for all this?
How are you going to pay for it?
Me personally, the big bet. I got a couple of buttons. That's perfect. Thank you. Good afternoon, everybody. I am what's keeping you between here and your refreshments, and so I'll make this quick, but I wanted to give everybody an overview of, we had some great presentations about how the climate is changing and how are these effects impacting real people's lives. That was a terrific presentation. Thank you very much from student from Quinnipiac. That was very heartfelt. I appreciate that. That was very nice. And so best of luck to you. Okay, from an insurance perspective, I've been doing insurance now for about 30 years, and so I kind of know the ins and outs of what's going on this. I'm going to make this really quick and kind of overview of how the insurance works and how, some different statistics that you may want to take into account. What's the definition of group medical underwriting? Basically, what we're trying to do is we look at a group demographics. Let's say we have a group of 500 employees. We take a look at what those demographics are. We take a look at their claims history. We're going to spend a couple of minutes going over, as Rick mentioned here, that I had 10,000 clients. I didn't know what he was going after. We have a database with over 40 million people, individuals in it, that can help predict how things are moving and how claims are moving and how the climate change is affecting these types of claims going forward. So it's a great pool of information to use, and we use it on a specific basis as well. For clients, medical and pharmaceutical trend, we'll talk about that as well. Help in the prediction and control of future increases of medical costs. Some claim statistics. Overall, when you spend $1 for healthcare and health insurance and healthcare costs, the claims, where did that dollar go? Well, about 31% goes towards inpatient care, hospitalizations, care in hospital, tests in the hospital, about almost a third of your dollar. Outpatient services, the doctor visits that you go to for wellness, the ones that you go to for sick, those types of services are about 20%. Professional services, the doctors that you're seeing out there, and pharmaceutical trend. Pharmaceutical is about 15% of your overall dollars now. It's probably even growing from there, maybe even 18% of your dollars, depending on the group. I have some groups that are probably 23% of their overall healthcare dollars are pharmaceutical claims. This is something that's growing quickly. We talked about how are we going to get through these, not only, that slide was great about how you develop the drugs. That's enormous. And it takes a lot of money to do that, but it takes a lot of, how are we going to pay for it all? And so that's, a lot of it is going from your insurance dollars are going to help pay for that kind of development. Annual trends, medical trend. Everybody hears about medical insurance going up and everybody gets their premiums around this time of the year and open enrollment. And you start thinking to yourself, okay, what's causing a lot of that increase? Right now, over the last probably 5 years, there's been a trend of medical costs, the actual cost that we talked about here a couple slides ago. Where was I? Here. The inpatient, outpatient, professional services, those types of claims, those are relatively, I say, in control. 5 to 7% increase per year. So if you go for a service this year, it's going to cost for the same service 5 to 7% more next year. I hate to say that that's within control, but in medical terms, it was going up probably 12, 15% a year a number of years ago. Pharmaceutical, though, is increasing at probably 15 to 20% per year. A lot of that is due to specialty medications, injectable medications, because a lot of the drug manufacturing companies are focusing in on drugs that they can make some money on in the future. And so it's an economic decision that they're making, but that's increasing your cost overall. So that trend is going up 15 to 20% per year and growing quickly. Some statistics, high cost claims. So if you look at a population of 500 employees, or however large it is, it's a little bit more predictable. 5% of that population is probably going to have somewhere between 50 and 60% of the overall cost dollars for that year. So let's say a 500 employee company is $5 million worth of healthcare costs that year. So in that general ballpark, 5% of those employees. So what is that? What's 5 times 5 is 200, is that 24 somewhere in $2.5 million or more worth of healthcare costs. But you never know who that's going to be. Specialty care, and I'll get to that point in a second. Specialty costs, drug costs. This is really interesting. I pulled this off of the, this was a CVS website, actually. This was a CVS website that I pulled this off of. Back in 2012, specialty drugs, injectable drugs, was about $87.1 billion. And again, that's overall U.S. statistics. In 4 years later, right around now, it's almost $200 billion, $192 billion worth of costs. They're estimating it's going to be $400 billion in another 4 years. So you can see somebody's got to pay for all of these medications, and this is why you see on every corner, you stop at a stoplight, and there's 2 drugstores on every corner practically, and they're all in it to make a little bit of money. Risk management techniques. So what do we do with that 500-person company? How do we help manage this and this cost expenses? Analyze the tool, analyze the information as best as possible. The data analytics that we are being able to draw upon is fascinating. Again, I mentioned 40 million individuals that we're drawing a database from, is that we are going to be able to do some predictive modeling. And we say, based off of, we don't have any names in there, we don't have any addresses, we don't know who this person is, but we can say, based on they went to this doctor, they had this prescription, they had these tests done, we can predict, and maybe it was only $10,000 worth of claims this year, but based on that trend, we predict that that person's going to have $250,000 worth of claims next year. And that's kind of interesting stuff. So the company can then help risk manage that. How do you place the insurance and where programs do you put into effect? In addition, population health management. A lot of companies call this wellness programs, and maybe many of your companies that you have insurance programs are asking you to participate in these. Do so. Please do, because what they're able to do, though, is if we can get you to go to the doctor to catch that thing early, that $10,000 potentially doesn't turn into $250,000. So again, go for your wellness exams, go for your screenings, go for your colonoscopy. I know it's not comfortable, but go for them because you catch things. Cost transparency. What we're trying to do is have employees, we talked about the iPhone, the generation is my kids live on the iPhone. I don't know if the data goes out or if the cell service goes out, they don't know what to do. They actually have to look at each other. But cost transparency, I need to be able to get into your hands. The doctor says you need to get an MRI done and you need to figure out what you're going to do, how we're going to attack something. There's a big difference where you go to a facility, how much that cost is. So I need to get that information into your hands when you need it. And that's coming. That's technology and that's coming along the lines, but we need that. And pharmacy management. How can we help? We talked about the manufacturing of the drugs, but the distribution of the drugs. We got it through approval, we got it to that. Now I have to get it to you. I have to get it to CVS. I have to get it to Walgreens. And it's amazing how many hands can touch it. And they all are taking a little bit of a piece. They're called pharmacy benefit managers, and they all have different prices associated for the same exact drug. So what we do is help companies manage what the best price is for those drugs. Circling back about the diseases. According to the CDC, the most common environmental hazards that we are really going to be looking at are air and water pollution. We've been talking about this, asthma, cancer, and lead poisoning. So these are the things that drug manufacturing companies, doctors around the world are going to be focusing in on. This is an interesting chart. This came from the CDC as well. And so this is asthma prevalence in the United States. If you take a look at this, going all the way back to 2009, when I was growing up, I didn't know anybody who had asthma. Maybe one or two kids that were on the playground that had the inhalers. But now, there's a significant change. And so is it all climate change? Don't know. Is it maybe food-related allergies that have resulted from the climate change? Don't know. Do they all play a role? Probably do. And so, but we're seeing that the statistics of people who have asthma are going up significantly. We have to figure out, A, can we control it? B, is how do we pay for it and get the kids healthy? According to the World Health Organization, this is a lot of words on this slide, but I wanted to kind of squeeze it down. This is the second to last slide, and everybody gets refreshments in a couple minutes. Is that poor environmental quality. We were talking about changes in climate, but the environmental quality kind of sums it up a little bit more as well, is that we'll be responsible for 1/4 of all preventable illnesses in the world. So again, that's something that this is from the World Health Organization. This is what they're seeing. What we're finding is that these governmental agencies are able to and are putting in protocols and putting in studies that are going to help us. We talk about data mining. On the claim side of things, the data mining and the statistics that these World Health Organizations, the CDC, are going to be able to do, the UN are going to be able to do, is consolidating that information in real-time, actionable information on directions of where things are going. So again, we can all see it. We just have to figure out how to address it. Every day we encounter these things, the chemicals, physical agents, and all these other things. They're all over. They're all over the place, and they are responsible for our overall health. Okay, medical underwriting, climate change and medical underwriting, my last slide. These changes in climate, they're not just a single issue that we have to monitor. There are many, many issues that we have. The drug manufacturing, we have the actual climate change itself. How are we going to address it? How are we going to get this onto a world basis, not just here in the US? So there are many different things that we have to monitor. Governmental agencies continually develop useful tracking statistics. Just mentioned that a couple minutes ago, is that that's critically important, because then when we have that kind of information, we can say, okay, let's address it somehow. If we don't have it, it's a very generic thing out there, and we can't necessarily address it. Use of large data pools in the development of specific things that we can address and how we can address them. So again, data analytics in these studies are going to be critically important. Thank you very much.
So I hope that one of the things you get out of that is that, so how do we measure this? So if the climate changes and it's gradual, how do you find the diseases that then Larry can look at through his data mining to figure out what, then tell the research world to figure out how to fix it. So these are just not idle things, and Mark gave the overview of what happened in Americas. Today is really about how do you make that operational, and what are some of the components. So hopefully this has been helpful, and we got a good, just a sense, and I look at this as more as a conversation of how do you take, climate change is not just a weather pattern, storms, floods, it's all that and much more. And the difference is it'll take 20 years, even if you start today, and you do what you're looking for to get therapy out there. So again, I thank everybody for being on the panel. And again, thank you, Sarah, for your wonderful sharing with us. I'd like to do, it's 4 o'clock, actually 5 minutes behind. I'd like to take maybe 20 minutes. Those of you who may have to leave, fine, but those who can stay, we take 20 minutes, ask some questions from the panel, and then we will break well before the 4:30 time frame. So with that in mind, are there any questions? Yes, please.
I'm playing camp for the peace action. I've studied for quite a while with diseases. Being explored by the military, and was told a long time ago to get the book Tomorrow's Weapons, which details how you could use vectors, mosquitoes, fleas. This was written in 1964. Talks about using drones, talks about using weather fronts to spread diseases. None of this is happening accidentally. They actually bred mosquitoes in Canada in 1957 and dumped them in Punta Gorda, Florida, creating Epstein-Barr at that time. They also dumped mosquitoes in the St. Lawrence area of Canada in the 80s. And now they're dumping genetically modified mosquitoes in Florida to combat Zika. How do we know they didn't dump the mosquitoes there in the first place as they have done historically? So I'm concerned about whether it's a weapon, the compatibility of that, combined with disease is a weapon. I would like your opinion on that.
So your question is, one more time, please.
How much have you looked at military experiments? For instance, my husband was in the Air Force during the Vietnam War, and he engaged in an experiment. And in Antonio, found out later that the head of the medical department there was a former Nazi scientist. So they use our soldiers experimentally as volunteers.
I think it's a great question, but I'm not quite sure the answer. I can't, George?
I surely can't answer that question. But I will tell you that the several meetings we've had recently, relatively, let's say over the last 5 years, with the military, it was involving countermeasures for germ warfare, that their level of concern and sophistication and being afraid of FDA, believe it or not, some of these captains and colonels, they still worry about the FDA. So what may have happened in the past, let me know about some experiments that were totally unethical. But I think there is an attitude now that people are following rules, but I have no specific experience, except the people we have met seem to be quite on board and straight on. That's all I can tell you today.
Okay, thank you. Any other questions? Yes, sir.
Thank you very much. First, I'm Jeffrey Huffines. I'm the Civicus World Alliance for Citizen Participation, Elon Red, based here in New York. And I want to thank all the panelists for a very fascinating discussion, your presentations. You are certainly demonstrating the multi-dimensionality of climate change, which goes well beyond the rather disappointing political rhetoric in this presidential election season. two questions. One is to John Laurie. Actually, I was sorry that you had very quickly dismissed the slide on the Paris Agreement. But I'd actually like to get some of your insights as to the impact of the Paris Agreement on legal developments here in the United States. I mean, for many members of civil society, NGOs, the Paris Agreement is a disappointment because it is voluntary. It is no longer a treaty. It doesn't follow the treaty model for legal obligations. So I'd like your views on that a little bit. And Larry Cass, I'd like to ask for your reflection on the use of the profit model, if you will, in the delivery of, let's say, universal health care. I mean, the notion of universal health care is that it is an aggregate public good, which requires the universal participation of all citizens, of all individuals, both healthy and unhealthy. And yet, during these last 20, 30 years, and I would say this presidential election kind of is this has been a source of much concern. The last 20, 30 years, we have a economic model whereby we have the privatization of public goods. And healthcare is just one example. There's many other examples. And so we're now in a situation, it seems, and I think the Obamacare it typifies this, whereby millennials, who are largely among the healthier part of the population, are deciding to not participate in the healthcare regime, thus leaving the sicker population dependent on a privatized healthcare regime, and consequently, the costs of our healthcare are just going through the roof. So I'd like your comment on a profit versus non-profit, let's say. We don't need to get into single payer system, but anyway, just in a more general sense,
So Larry, why don't you take that question first, and then just give John a chance to think about it.
Thanks, Rick, and thanks for that one. I was actually toying with it's fascinating, but I was toying with looking. I have a slide that actually addresses your exact question. Is that it shows the other advanced countries around the world saying, okay, where's their healthcare dollars over the last 10 or 15 years? And it's a fascinating. You see all of them bunched up within 1 or 2% of each other overall. It just goes along and fairly flat. And then you have the U.S. all alone up top, and a bar that's going up at a different angle. Mm-hmm. And you look at it and you say, okay, what are we missing here? And so, unfortunately, is it the beast that we have that we have to work with? It is. Is it the most efficient way of developing drugs and delivering care? Probably not at the end of the day. If we can get everybody in one pool and actually manage it, rather than, this is a comment on Medicare. Medicare just pays bills. They don't manage things. If we can have everybody in the pool and manage the care that people get instead of just paying things, then we're talking about being able to be a little bit more controllable and a little bit more sustained. So I can't necessarily stand up here and say that we're going to fix it today, but what we're trying to do is measure as accurately as possible how can we address these things and control it within this beast that we have in the U.S. right now.
Yeah, I'd like to make a point on that. Sure. Hello. Okay. When you take a look at healthcare, now I am not the scientist, but it used to be about 90% of your total health bill for your life gets paid in your last year of living, basically. Is that sort of what's still happening now?
Maybe 3 months.
Maybe the last 3 months. So when you talk about healthcare, and you talk about if you look graphically on a graph, you can see that at least 90% of the total amount of healthcare that you pay in your entire life is accumulated in the last 3 months or 3 years or whatever, how do you make the decisions on how, and as healthcare gets better and stronger, there are major decisions that have to be made along the way of who is going to pay for that last year of your life, or the and the unlimited amounts of dollars that it costs are incredible. I mean, I had a little thing with my eye, and I had a $200,000 bill, and it's unbelievable. How do you do it? So I think that has to be put in, and that's why they were always talking about, if you have these public health systems, there will have to be, I don't want to use the words they use, but they have to be decisions made along the way. And that's something we as a society really have to decide on. So,
just one quick additional comment. This is a lot, we can talk all day and weeks on this, is that they've shown, and just a paper that I think just came out today, but they've shown that in oncology, at a certain point, palliative care, the outcome actually in terms of longevity and quality of life improves if you stop treatment, but just take care of people and give them support. So this whole thing of end of life, I mean, all these things are, I think, key to solving problems.
Great, John, are you ready for
What's the question?
So the question was, if I've got this correctly, is when we look at the Paris Agreement and whether or not it was a success or a failure, I think it was actually a success, all right. How does this affect, or what effect does this have in the United States, considering the fact that it's not a binding agreement we haven't yet, correct? Right, yeah. So I think you can look at what happened with the Clean Power Plan. So the Clean Power Plan is proposed by the EPA, released from President Obama, proposed a significant reduction in greenhouse gases statewide. The problem is that certain states rely on the coal industry. And the coal industry affects jobs. And there wasn't, what I understand, the challengers say, is there wasn't an adequate technology to achieve the goals of the Clean Power Plan. So thereby it was challenged, because in order to succeed, the challengers say that you'd have to shut down the coal industry. So what does this reflect in the United States? What this reflects in is that you need a Congress and a president who's amenable to taking steps towards fixing greenhouse gases and lowering the rate of emission. Second, we need technology to really be applied to this. And perhaps there needs to be a national plan on funding the development of technology in order to achieve the goals of lowering greenhouse gases. Because in the past, the EPA has always said that we're going to lower emissions, but there's been technology generally available, scrubbers and other things, to achieve the goals of the EPA. And finally, we have to work within the system, and we have to figure out in the United States and maybe the rest of the world, what are we going to do about providing individuals and families with the ability to feel valued in having a job or feel worth in doing that, and will we eliminate that? Right now, I don't know what the current Congress will look like. I don't know what the new president will do. We all suspect what he will do, but we're not sure what will happen. We might have to wait for another change in administration. We might not, but that's my view on it. And I had to ask Mark to comment. He's really been much closer to the Paris Agreement.
thank you.
Well, I mean, I'm coming at this from an NGO standpoint, working within the UN system, but also working with other NGOs from the Caribbean perspective, working with the Caribbean region, but also working with NGOs based in other countries. What was particularly interesting being in Marrakesh was, first of all, getting an insight on what these negotiations look like. Am I going to be in a room with 199 representatives, and are we just going to be looking at this draft document for 2 weeks, or is it more flexible than that? Are NGOs given the real platform for discussion? Do they influence these negotiations? Do they have any say? And actually, I was quite inspired because I really thought after Tuesday night that it was going to be, that was pretty much going to be a stall on all the negotiations. But despite that, as I said, the structure of the negotiations allowed for many exhibits by NGOs, many side events and discussions between member state delegates and NGO representatives, private sector representatives. And I think having that forum available to delegates was a source of reassurance to them. And on the Wednesday after the results of the presidential elections, yes, there was definitely a more subdued feeling throughout the conference, but there was this understanding that there is a legal mechanism in place. It does take 4 years to get out of this agreement. It is there are certain voluntary obligations, but there are obligations nonetheless under international law. That the US in itself has invested somewhat in low carbon solutions, so it's kind of a machinery that's in place. So a lot of the private sector representatives that were there at the business forum said, well, President-elect Trump is a businessman. I think he understands the business perspective, and I can't see him divesting completely from these engagements. That being said, he has appointed a climate skeptic to the head of the EPA, so that's a bit of a troublesome fact to take into consideration. That being said, there are 199 countries party to this agreement, so this is one country, and it's not the Kyoto Protocol, which had a lot less people signatory to it. So there's a momentum, and it's a very different political reality to when the KP was signed in 1997. Countries like China, who are heavily polluting countries, are also heavily investing in renewable energy. And it's a threat to the US if they don't follow suit on those types of investments. And I think this reality at the negotiations, to me, that was a learning curve. And I think that was a very inspiring environment to be in, despite obviously the shortfall, what I was alluding to in the UNEP gap report, that there is a shortfall in what commitments we put forward, what we're on track to meeting, and what further efforts need to be done. It's more a way of leading the way and showing, that there is a side community of climate advocates that are here at this conference that are going to go away and they're going to plug the gap. And I think the US is one of the countries at the regional and city level that have always shown the way, been very entrepreneurial. Cities like Seattle being carbon-free and carbon neutral, and on a regional level, setting up other policy tools like emissions trading schemes on the East Coast and West Coast. They might not be present within the Midwest, but there's definitely at a regional level a lot of initiatives to plug the gap. And I think the Paris Agreement really is a kind of a beacon of hope for these sorts of communities. And the fact that there has been there's a different political reality about to come into play is going to be more motivation for these other communities to fill the gap. So I think it is worrying, but I think there's also a lot of inspiring change taking place at the moment.
Great. Thank you. I'd like to, at this point, I've asked the panels members to stick around after, but I will thank everyone for being here, and I hear tiptoes behind my face and my thing here, so I'll let Aaron here take us home, as they say. Thank you.
First of all, I'd first like to thank Rick and all the panelists for being here today with us and giving us different perspectives. But before we break up, the purpose of having these programs as a non-governmental organization, as an NGO, as several NGOs, because all of us come from different parts of the community, is really to recognize that there's a lot that we have to learn, but there's a lot that we can do. And I think the representatives, whether they're from individual NGOs, whether we're activists, whether we're professionals, the gap between knowledge and action is always there, but the hope of this sort of program is with the education to be able to follow up with action. And so I really encourage all of us who are here today, the one way that we can thank our panelists most is to individually take action that's relevant to where we are and what we do, and try to recognize that the challenges of children's health, the challenges of climate change are going to be with us for a long time to come, but we really can take steps, each and every one of us, to help bridge that gap and to advance the process. So again, thanks to all our panelists, our moderators, and thanks to you one and all. Don't forget to use the facilities here to have something to drink, and if you haven't signed in, please take some of the materials that are on the table there. Those include organizations that would like to join the Council of Organizations. That includes materials on one of the activities of our parent organization, USA. That activity is to support a peacemaker who's given his right arm to service in his home country of Somalia. So there are interesting things on the table. Please stop by to see them, and thanks very much for your help.
Very nice to meet you. All right, all the best. Yeah.